My name is Mohammed Al-Salam, and I'm very happy to share my presentation here with you today, titled Anti-VEGF Use in Uveitis. As in any presentation, we will start with a problem. And ours is inflammatory retinal and choroidal neovascularization. As you all know, uveitis is the third most common cause of choroidal neovascularization, following only after age-related macular degeneration and pathological myopia. Another scenario, in patients with occlusive retinal vasculitis, we have significant capillary dropout and non-perfusion. This will set a cascade of events that will eventually release a number of growth factors. If untreated, our patients will end up with vision-threatening complications, such as a fundus obscuring vitreous hemorrhage, attractional bands, and epiretinal membranes. And hence comes our treatment. Anti-VEGF, we can all agree, have revisionalized the treatment of many retinal vascular disorders, and it's only appropriate to describe its role in the management of uveitis-related vascular injuries as being expanding. So the solution is simple. We need to find a way to integrate anti-VEGF in the management of uveitis-related vascular, retinal, and choroidal injuries. Now, a key rule and a point here, you don't need only to give anti-VEGF for those patients. You should address and control the underlying intraocular inflammation first. Otherwise, if we give anti-VEGF alone, we will be just like silencing VEGF while the orchestra is still playing. Over the next few slides, we will show a number of real-life patients. Those patients with uveitis came to us, and we find a way to integrate the use of anti-VEGF in those uveitis-related vascular complications. So patient number one is a middle-aged female from Al-Hilla, Iraq. She presented to us with no significant past medical or surgical history, and she has a sudden onset of visual loss. Initially, she has some evidence of granulomatous uveitis, but when we thoroughly examine the patient, we have an evidence of an occlusive retinal vasculitis in the right eye and a fundus obscuring vitreous hemorrhage in the left eye. So this is the Optos ultra-wide-field fundus image of the right eye. You can clearly see the vascular sheathing, the sclerosed blood vessels, particularly temporally, the retinal hemorrhages, and the choroiditis. And the choroiditis follow the blood vessels. These are very distinctive pattern of choroiditis. They usually seen in patients with TB, presumed TB uveitis. The fluorescein angiography show an extensive area of capillary dropout, particularly on the temporal part of the fundus. And you can see the hyperfluorescent leakage pattern suggestive of retinal neovascularization. So the picture is now different. We have a fundus obscuring vitreous hemorrhage in the left eye, and the right eye have occlusive vasculitis. We completed our workout. We sent the patient for an EGRA, tested positive for TB. We sent the patient for a chest CT scan, show us an evidence of a previous pulmonary TB infection. And our patient have a characteristic skin lesion on her nose. We sent her for a dermatologist, and the dermatologist confirmed that this was a lupus vulgaris, one of the lesions that you can see in patients with tuberculosis. And by the time we do the workout, within 1 week, the patient presented with the seeing eye, with the good eye. Now she develops vitreous hemorrhage. It was a little bit late for us. So it was an opportunity as well. So we decided to give anti-VEGF for the right eye. It has the fewer and the smaller amounts of vitreous hemorrhage. And for the left eye, we proceeded with pars plana vitrectomy. Initially, we have a vitreous hemorrhage. We remove it, and we try to give in a similar pattern to the right eye of the temporal part of the fundus. Now, this is our patient's left eye Optos wide-field fundus image, and you can see the laser marks and the capillary dropout. She still needs more laser to be added post-op in her left eye. And for the right eye, after a single injection of anti-VEGF, we give laser photocoagulation for the temporal part of the fundus. And now the patient is resuming his daily life. And more importantly, even the skin lesion of her nose has been disappeared. We give her anti-TB treatment along with systemic steroids, and we find a way to integrate anti-VEGF into the care of this patient. Patient number two is a similar story. Once again, this is a middle-aged female from Baghdad. She presented to us with no significant past medical or surgical history, and she has a visual loss in the right eye for more than 2 months. Now, once again, there were features of granulomatous inflammation, and this is the fundus, the Optos wide-field fundus image of the left eye. Once again, you can see clearly the tubercles, the choroidal tubercles, along with vitritis in the left eye. The right eye, we have a fundus obscuring vitreous hemorrhage, and we cannot see. So we proceeded with surgery. This was a diagnostic vitrectomy. We really didn't know what was sitting behind. Obviously, we left the patient aphakic. We weren't sure of the diagnosis or the control of the intraocular inflammation. Once again, she has a vitreous hemorrhage in her left eye. And after we cleared out the vitreous hemorrhage, you can see there is an ill-defined whitish elevated lesion at the macula, along with an adjacent area of subretinal hemorrhage. We believe that this is to be a presumed choroidal tubercle complicated with choroidal neovascularization. Now, intraoperatively, we give intravitreal anti-VEGF for these patients. And this is her right and left ultra-wide field fundus images of the right and the left eye. And this is the post-op image of the right eye, as you can see. Now we give her anti-VEGF. This is the initial one at the beginning at the top of the screen. And this is after 2 months. It's starting to decrease. And later on, we give her a third injection and a fourth injection. And this is the result after 5 months. The choroidal neovascularization is starting to regress. What's even more surprisingly, that the choroidal tubercle is also regressing as well. Now, this wasn't one guy's job. This was a team effort from mentors and other staff members who helped me a lot through this journey. Thank you for your listening.
عشت دك